kind introduction. A very good evening to all of you. And as she had already highlighted everything, I will be talking about the ROS testing in the routine semen analysis. Though a lot has already been covered by my colleague Dr. Sarabhi, very elaborately he has covered. And when the topic of ROS and routine semen analysis were given to me, I was like, okay, it's just ROS and DFI are basically interlinked. Having done both ROS and DFI testing, left, right and sending along with the gene expression analysis and all that, I was like, okay, let me concise and take a part of Dr. Sarabhi's talk. So, was to say, I don't have any conflict of interest since some of the ROS testing, the instrumentations would be now coming up in my presentation. So when we talk about the redox regulation in the sperm as well as the oxidative stress, they both have become one of the key areas of interest. Why? Because of potential limiting effect of ROS on the sperm DNA damage. Both oxidative stress and elevated level of seminal and the semen ROS levels, they may contribute to nearly 80% of male infertility diagnosis. Impairment in the redox hemostasis has been highlighted as one of the chief causes of not only the impaired sperm function, but also it is a key indicator for disruption in the genomic integrity and may further contribute adverse consequences on the fertilization and the early embryonic development. So before we go further, I just would briefly give you a gist of the sperm genome as such. We all know about the sperm histones, the histones in the somatic cells. These histones in the sperms, they are basically converted to protamines. Nearly 80 to 85% of the sperm histones are converted to protamine. If you can see the image here, the central light blue core is actually the protamine rich region, while the peripheral 15% is only which is in the periphery is the histone rich. And this peripheral rim of histone rich rim in the sperm nucleus is the one which is predisposed to the oxidative attack. Why I am saying so? That because of this rim is the one which is rich in the guanine bases. And these guanine bases are the one which will further mutate, have mutagenic risk to convert to the cytosine bases. And not only this peripheral rim of histone rich sequences are the one which have the genes for, which is highly show expression changes in the genes as well. And the sites for telomere expression as well. So, highly said that the sperm DNA which is highly condensed in the center and the peripheries, it shows that the sperm is actually, it exists in a state of oxygen paradox. So many predisposed to be attacked by the oxidative radicals. What are these radicals? That we don't only have the reactive oxygen species like we have here, a lot of them. They're not only radicals, but they're also non-radical species, but also various reactive nitrogen species. When we talk about the oxidative attack, it's just not ROS, but also the detrimental effect of the reactive nitrogen species. And you can see that there are a host of elements here. So if we see the classical cascade, when we talk about the oxidative stress, though there are various oxidants which predispose the sperm DNA, but why is it that the sperm is predisposed to be attacked by the oxidant? Because sperm inherently lacks the antioxidant defense mechanism. It lacks the basic antioxidant defense mechanism, and if the person already is in a state of less antioxidant in the body, he's more prone to be attacked by the oxidants in the body, right? So we can see that basically the antioxidants are both enzymatic and non-enzymatic antioxidants, and how the superoxide dismutases and the hydrogen peroxide, they will lead to the cascade of production of the oxidants. So the sperm does not only have the endogenous but also various exogenous sources. When I talk about the endogenous sources, they lie within the sperm cell itself. Chief of it being the mitochondria. We know that mitochondria are the powerhouses. They have the ATPs in them. They are not only the aggregators but also the propagators of the ATP reactions in the mitochondria. All these enzymes, basically sperm is itself synthesis of oxidants. But also if there are various immature sperm cells, presence of leukocytes, Sir has already highlighted on it. Leukocytospermia in the semen is the main cause, is a very much predisposing factor for oxidative attack. Also varicocele, patients have higher oxidative stress. And there are various exogenous factors like various lifestyle factors, environmental pollutants, toxins, pesticides, everything, various infections, inflammations, the drugs, advanced age, yeah, and ART sir has already highlighted about. So what happens when this balance is disturbed? One thing is that in physiological levels, these ROS are actually helpful. They facilitate a lot of physiological processes, but if they are excess, they will lead to the loss of plasma membrane fluidity. We should know that the sperm membrane is actually very rich in polyunsaturated fatty acids, the PUFAs. The fatty cell membrane is predisposed to be attacked by the oxidants, right? When attacked by the oxidant, it leads to the loss of membrane fluidity, leading to the loss of the sperm motility. Yes, ROS levels increase. The first thing to be affected is the sperm motility in the sperm, right? It impairs the mitochondrial function, which in turn affects motility. It also causes the oxidations of various lipids and sugars in the cell membrane, affecting the gamete recognition, like sir said, affecting the zona reaction, affecting the gamete recognition. It hampers various peroxide signaling pathways, which impairs the fertilization. And last but not the least, very pertinent, is causing the sperm DNA damage. When I talk about the sperm DNA damage, those are as taught, it is because there is a mutagenic risk to the offspring. What does this mutagenic risk is there? That the sperm DNA, the guanine bases in the DNA are very much predisposed to be attacked by oxidant. That mutagenic conversion is from the guanine to the cytosine bases. With the ROS, these guanine to the cytosine base conversion, there are mutagenic risks associated and causes the DNA damage, which not only are various single strand breaks but various extensive double strand breaks, etc., leading to not only the lack of pregnancy but also risk of miscarriages, risk of implantation failures, slow embryo kinetics, poor embryo development, etc. Right? So essentially this is oxidative DNA damage, but what is the level of this DNA damage? You know, if the patient is predisposed to just very few oxidants, what type of effect it will be? Basically, the DNA damage caused by very low ROS to high ROS levels actually differs. What happens is, you can see in the paradigm, as the increase of the oxidative stress intensity is increased, that's how the damage increases, not only causing the oxidation but AB excised to cross-linking and further to the DNA strand breaks, right? It has been discussed already, but I'm just reiterating it again. Oxidative stress is also induced in the ART cycles, like various, this has been already highlighted. This is what I was thinking, sir has already touched upon a lot of things over here. That there are the various reasons by which the oxidative stress is created in the ART cycle over the sperm cell preparation in the IVF. So what all we can do is, like the antioxidant activity of the space, what happens if the antioxidant capacity of the seminal plasma is further removed during sperm washing steps as well, apart from all these things. So at every step, as I said, we can actually tend to limit what is being done, right? And therefore, we should be using the procedures that minimize the multiple stratification, resuspension and vortexing, etc. for the semen preparation in the IVF cycles. There have been studies, many studies which talk about the ROS levels in the ART cycles, but also in procedures with in vitro maturation. When the IVF cycles with in vitro maturation is done, then also there is an increased risk of ROS affecting the sperm metabolism. There's one interesting study which was shown by Dr. Agarwal and all, that yes, there is an increase in levels of the oxidative stress in patients who have leukocytospermia, leading to increased DNA damage. So what they shows that it has been various cutoff levels were established. This was a very interesting study. They had taken the cutoff levels, established different cutoff levels for the patients with going for the normal cycle to patients who had high ROS levels and with impending increase in the leukocyte levels in the semen, etc. So I will be touching base over little more studies as well. But what do we do when we have high ROS levels? Are we routinely doing the analysis of the ROS levels? No. Though at AIMS we do, for the patients, we are doing routinely the ROS testing for patients with infertility and recurrent miscarriage and IVF failures, etc. Initially, it was not included in the WHO manual for semen analysis, but the latest WHO laboratory manual for the examination and processing of human semen released in 2021 states that oxidative stress has now been included in the advanced examinations of the semen, as well as the evaluation of the sperm DNA damage has also been included in the extended parameter of investigations. This oxidative stress is not cited alone in the advanced examinations, but also is along with the ecrosome reaction and also the assessment of sperm chromatin structure and stability, along with the various transmembrane ion channel effluxes, influxes, potentials, etc. When I talk about now it is being involved with the advanced examinations, it was in 2018 that the ASRM guidelines had stated that now the sperm DNA damage can be done in the patients. Before that, neither the ESHRE guidelines nor the RCOG guidelines had imputed even the sperm DNA damage. So it has now been done in the 2021 WHO manual. So when it comes to quantifying the levels of these ROS, what do we do? They're both direct and indirect semen assays for estimation of reactive oxygen species. What would the direct assays do? They actually measure the ROS production and the sperm cell oxidation. This is done by these tests as such, out of which the most common one which is routinely done is by the chemiluminescence. This is by the luminol-dependent chemiluminescence analysis, and whereas the other methods are also done along with the flow cytometry. I don't know if many of you have heard about the flow cytometry and the chemiluminescent luminol-based analysis being done for the ROS analysis. Whereas the indirect assays, they are done to evaluate the oxidation by measuring the various downstream markers of injury from the reactive oxygen species. So that is why they are the indirect factors. It is when we measure the levels of these antioxidants, various chemokines, we assess for the DNA damage, we assess for the various lipid peroxidation levels. When I mean by lipid peroxidation, I go back to the fact that when I said that the sperm plasma membrane is rich in PUFA. Oxidative stress, it causes a lipid peroxidation. And when it causes a lipid peroxidation, there are certain aldehydes which are formed, which are estimated. This is an indirect method of estimation for the ROS, like malone aldehydes, etc. Also, the measurement of redox potential, the measurement of oxidative reductive potential, which was recently patented, and also the myeloperoxidates or the ENDS test. So, what are these tests all about? Basically, chemiluminescence will detect the oxidation or reduction through the generation of the light. That is a probe which is a luminol which is there, and uncharged and charged probes would undergo either oxidation or reduction, and they would generate a light which is being measured. Flow cytometry is for the mother measurement of the ROS measures. This is a little detail of all the tests. Actually, it would go a little more off the purview of the assessment of this talk today. But I would certainly want to talk about the various advantages and disadvantages of the same. When I talk about chemiluminescence, it is robust, it has high sensitivity and specificity, but what is there is that it requires basically large samples which are being done. It is time consuming and it is affected by changes in the pH centrifugation, and also when the semen sample was given and after what time we are doing the ROS analysis. The ROS level, the oxidant levels, it would vary from time for that. Right? And nitroblue tetrazolium test, it detects basically the intracellular ROS level. That is the advantages of it. And it will detect even very lower concentration of ROS can be detected. But with this test, the specificity of ROS detected is questionable. Cytochrome C reduction test is similar. I would now here talk about the recent one, the oxidative reductive potential, which is your ORP, which is determined. Again, it was one of the tests which was given by Dr. Ashoka Agarwal's group. It is a simple, less rapid. It would just take 4 minutes. Many samples can be done, and as the luminol chemiluminescence can be done only in the fresh sample. This test can be done in both fresh and preserve or the stored semen sample as well. That is a bigger advantage it gives. It gives the ORP levels, but still it needs further standardization evaluation. And this test has been included in the WHO manual as such, right? And these are the indirect tests which I've already talked about in a gist. I would go further, right? Various tests in STEM have been done, various studies have been in circulation for the assessment of oxidative stress, but along with the DNA damage. I would take another 3 to 4 minutes, please, I'm sorry for the same. Our study also at AIMS, we had established the cutoff levels for in patients with uterine pregnancy loss, IVF failure patients, as well as patients who have gone, male partners of couples who have undergone, who had previous babies with congenital malformations. This was a study from our laboratory. Another study by, basically more of the studies I found were more by Dr. Ashoka Agarwal's group. Initially in the study they said infertile men, irrespective of the clinical diagnosis, have reduced semen parameter at elevated ROS levels. And so they had stated that measuring of the ROS levels, they would provide clinically relevant information to the clinicians as well. The oxidative stress levels have also been measured with the sperm morphology. In fact, even in our studies, we had found that semen samples, men who had higher ROS level, they had more range of morphologically abnormal sperms in their semen. This was another study. We can see that the state of leukocytospermia, increasing ROS levels with the increased leukocytes in the semen. This is one of our study. This is a reiteration of the same. I've had further talked on more studies, but much has already been covered. So when we talk about these parameters, all these factors, oxidative stress affecting all these factors, it also leads to telomere shortening as well. And telomeres are the one which are for the senescence. Telomeres, oxidative stress affecting telomeres predisposes the men for the sperm aneuploidy. And we can relate that now the sperm aneuploidy testing is quite much in the circulation. There's one thing that in the natural conception cycles, there is failure oxidative stress and DNA damage. But what happens in IVF? There's an ICSI paradox. Why would I call this an ICSI paradox or an andrological ignorance? Because we are bypassing the natural barrier, natural mechanisms. The sperm with DNA damage, we are making the sperm fertilize the oocyte. Are we checking the ROS levels? Are we checking the DFI levels? No. It is not routinely being done. In my practice, and I would not say practice, in my experience, whatever patients we had as such at AIMS, there were a lot of patients who had high ROS levels and the DFI levels. And when there is either fertilization, IVF or natural, there is defective DNA damage repair. Why defective DNA repair? Because sperm lacks the basic DNA damage repair machinery. It is dependent on the oocytes repair mechanisms. If not repaired, would lead to all the adverse effects. As stated, the ICSI paradox. Majority cases we are just doing the ICSI. IUI is also less being done. Men are able to achieve parenthood, but all these deleterious effects, they pass on to the next generation. They transmit various genetic and epigenetic defects further to the offsprings. It is not just at fertilization. I just have 2 or more slides. So what are we doing in the current clinical measurements of the ROS level? There were various tests, both direct and indirect assess. ROS levels are being done in patients when the abnormalities are observed during the standard semen analysis. When we have couples who are undergoing AIT, they have experienced reduced fertilization or embryo development days, reduced embryo kinetics, repeated IVF failures, as well as pregnancy losses. In the current WHO manual, 2 of these tests have been included. That is the luminol paste, that is a chemiluminescence, and the measure of oxidative reductive potential, the myoxis. They have now been added to the advanced examination section in this recent WHO manual. But from a clinical diagnostic perspective, this group of assays should only be used and interpreted with caution until we have more further conclusive proof of their diagnostic relevance. There are more studies which are being currently coming up. We should actually go with how we are doing our practice. While we evaluate the ROS concentration in the semen, it shows a potential diagnostic tool, but still no current mainstream guidelines have been still established now, though we have included it in WH, nor for which various tests have been performed. And also, normal reference ranges, or as we call the newly introduced term, the decision ranges. There are no clear normal reference ranges which are being cited. When do we take the normal reference ranges? These normal reference ranges are established with respect to a healthy fertile male, and the definition of healthy in the fertility spectrum is still questionable. When do we define healthy? Is it just with that the male has a healthy fertile child? Is that male called a healthy male? How do we quantify? How do we say that this man is healthy and we are taking the ROS level from this person? So these are all the lacunae which are still assessed with the ROS level. The ROS levels may vary from day 1, and if the patient is coming after 5 days to give another sample, the ROS may vary. So we suggest that most recently updated 2021 manual that the diagnostic predictive value of the ROS, they still need to be interpreted with caution. Thank you so much. Any questions?
Thank you so much, Dr. Presentation. It was actually a complicated topic, and I would like to seize this opportunity to thank Dr. Ravi and Dr. Natesh for this extremely focused and informative conference.
Thank you, ma'am.